This presentation will cover depression in children and adolescents and the treatment of. So just as a reminder, the presentation of symptoms of depression in children are different. The most common you'll see is irritability, anhedonia, social withdrawal, low self-esteem, sleep disturbances, decreased appetite, and during play they may exhibit play themes of suicide, self-destruction, or death. They are often commonly described as, or will describe being sad, lonely, having low energy, and they may be failing school. Other symptoms include physical complaints, boredom, difficulty with relationships, substance use, running away from home, acting out, and sensitivity to rejection or failure. SSRIs, selective serotonin reuptake inhibitors. Prozac or Serafem are FDA approved for treating major depression in children aged 8 years and older. It is the only one that is technically approved. All others are off-label. TCAs, tricyclic antidepressants. We've talked about this. They have significant side effects. They're toxic in overdose, so this is something that you probably wouldn't want to give to kids, because if a child or adolescent is in, it does happen, I know you're thinking, who would do this? But trust me, it does happen, in charge of dosing themselves, they could overdose, they could forget that they took it, and they could overdose. It also is, we've talked about this as being a risk of being prescribed to those who have any suicidal thoughts, because it is toxic in overdose. And it has resulted in 6 cardiac deaths in children. Research. Treatments for Adolescents with Depression Study, or TADS, was a federally funded research. The sample included 432 adolescents, ages 12 to 17, with major depression. They were randomly assigned to groups. After 12 weeks, the positive responders were 35% were placebo, 43% were CBT, 61% was Prozac, and 71% was Prozac and CBT. And I just want to point out this combination. Anytime you have medication with therapy is when you're going to get the best response. And that's hands down, because medication alone isn't going to do it. Okay, so there was 2 findings. The time to onset of positive medication effects may be longer for children than adults. Children's improvement were within 4 weeks, may need an 8-week trial. A syndrome of apathy and amotivation or emotional disinhibition is more commonly seen in children. All right, so treatment begins with low doses throughout the first week. If it is tolerated well, the dose will be increased. This is important because 5% of children have a 2D6 hypometabolism, which means it has inadequate first-pass metabolism of certain drugs, which results in high level in the bloodstream, producing substantial side effects. So that is why it needs to be started off low and then increased. It is suggested that a time period of 4 to 6 weeks should take place before medication is increased. This is preferred before switching drug classes altogether or augmenting. And augmenting is also known as adjunctive therapy, or psychopharm, so including another adjunctive medication. Activation, this is an important concept, and this is where your job as a therapist comes in. Activation is an acute onset side effect that takes place within a few hours of the first dose or an increase in dosing. It subsides in 1 to 2 weeks. This is anxiety, insomnia, and agitation. Predominantly anxiety is the symptom. This is not switching or flipping. So this is when switching or flipping is when an antidepressant is being prescribed is a monotherapy, so the only medication, and the person is presenting with bipolar. It can prompt or induce mania. Medication typically needs to be taken for 2 or more weeks. Educating clients and their parents is essential. And this is because one bad experience with medications can result in medication noncompliance, dropping out of treatment. That includes therapy. Activation of anxiety, insomnia, agitation that lasts 1 to 2 weeks. That sounds terrible. That's not something I'd want to do. So sometimes you have to think about being in your client or patient's shoes and what that would feel like, especially if that was your kid. What if that was your kid? So when this happens, Ativan 0.125 milligrams can be prescribed when activation is observed. As with adolescents, it is recommended that continuation of an antidepressant at the same dose for a minimum of 6 months after there's improvement of symptoms, and then a gradual decrease. So if Betty is feeling better in December and is continuing to attend therapy, December was that first month that she felt that she was doing really well. You are going to continue that for 6 months at that dose and then decrease, while maintaining therapy. Activation of medications. So these are the medications that produce a substantial activation risk of Prozac, which is an SSRI. A moderate activation is Wellbutrin, which is an NDRI, and a Zoloft, which is an SSRI. Mild is Paxil, Celexa, and Lexapro. Effexor, Pristiq, Cymbalta, Benzema, Strattera, and Brintellix. Possible activation response is Luvox and Remeron, and there is no activation risk is Trazodone or Deseril. There are 2 late onset side effects for all antidepressants, excluding Wellbutrin. That is apathy and emotional blunting and emotional disinhibition. Both are a result of a downstream effect of serotonin on the dopamine system in the frontal lobes. The apathy and emotional blunting and emotional disinhibition resolves after you GC the med, after you discontinue it or you introduce Wellbutrin. And the reason why that affects it is because it activates the dopamine neurotransmitter system. Many children that have persistent depressive disorder will develop major depression. Persistent depressive disorder can last at least 3 to 4 years if it's not treated. That is a long time for a little kid. That's a lot of their childhood. Antidepressants have shown to be effective in treating persistent depressive disorder in children. However, further research is needed to confirm efficacy. SSRIs or serotonin reuptake inhibitors, selective serotonin reuptake inhibitors, are effective in the treatment of premenstrual dysphoric disorder or PMDD. Patients often show a positive response to treatment within a few hours of taking initial dose. You only need to take that medication for a short period of time. NRIs and NDRIs are not effective for the treatment of PMDD. Next are psychotic symptoms related to a depressive disorder. So this would be someone who may have major depression with psychotic features. Majority of these children will present with delusional thoughts. So this, our classmates are putting poison on my backpack, or our car is bugged. Many of these children keep their thoughts to themselves. These children may be treated only for depression and not the psychotic symptoms, but when just antidepressants in itself is not going to treat the psychosis, so antipsychotics should be used in addition to the antidepressants. Discontinuation withdrawal is similar as seen in adults. Paxil and Effexor, they are reported to have severe withdrawal symptoms because of their short half-lives. Withdrawal from Prozac is rare, and this is because of the long half-life. Withdrawal symptoms can typically be avoided if they are titrated slowly for 4 to 6 weeks. And these are our sources for this PowerPoint presentation.